So we're back with part 3 of chapter 2. We're going to start with talking about clubfoot. Clubfoot is where the heel is drawn up with the lateral side of the foot being convex and the medial aspect being concave. So the outer side is curved outward and the inner foot is curved inward. So some sources suggest that fetal position is the cause, and other studies implicate genetic factors. Some notes here for you. Clubfoot is an obvious, non-traumatic deformity of the foot of the newborn in which the anterior half of the foot is adducted and inverted. So a true clubfoot cannot be manipulated to the proper position, whereas distortions that are caused by intrauterine position usually can be. So if they think that the baby's foot is drawn in or feet are drawn in because of the position that they were in the uterus, usually those can be manipulated back to the proper position. With clubfoot, however, that is not the case. Most cases of clubfoot are discovered during newborn exam. The deformity is obvious at birth with a resistance of the foot to return to a neutral position during manipulation. Treatment consists of either cast application or the use of splints. Casts are reapplied at frequent intervals as the correction increases and the infant grows. So it's not like they get one cast and that's all they get. They will reapply new casts at different times throughout the child's treatment so that they can continue to correct the clubfoot. Splints include a bar affixed to shoes. So here's the thing with treatment. Treatment must start early in the neonatal period. Many physicians employ a combination of manipulative methods with cast application followed by the use of splints as the child matures. Prognosis is pretty good for these kids when casting is performed or splints can be used early on in life. So the sooner that we start treatment for clubfoot on these babies, the better off they will be in the long run. So the child must be observed throughout childhood for reversal of the improvement. So it's important to make sure that they keep up on treatment plans. DDH is developmental dysplasia of the hip. It's previously known as a congenital hip dysplasia, so sometimes you may still hear it as CHD instead of DDH, which is developmental dysplasia. It's an abnormal development of the hip joint that ranges from an unstable joint to dislocation of the femoral head from the acetabulum. So it is a dislocation of the ball of the hip bone, or of the top of your femur, your leg bone, and from the socket, basically, the hip socket. This dysplasia is apparent during newborn examination. Physical examination reveals asymmetric folds of the thigh of the newborn with a limited abduction of the affected hip. The shortening of the femur is also noted. It occurs shortly before, during, or shortly after birth, possibly as a result of softening of the ligaments caused by the hormone relaxin. The exact cause of DDH is unknown. Diagnosis is made during the physical examination and is confirmed by ultrasound of the hip. Treatment includes the use of various devices to reduce hip dislocation. And by reduce, they mean to put it back in socket. After the femoral head is returned to its proper position in the acetabulum, the legs are held in place by a Pavlik harness or a splint or a cast. So early treatment is going to offer the best results for these kids. The prognosis for this deformity is pretty good when therapy is instituted early in the neonatal period. Cleft lip and cleft palate. A cleft lip is a hair lip. It's also known as a hair lip, I should say. It's a congenital birth defect consisting of one or more clefts in the upper lip. There's a hole in the roof of the mouth with these cleft palates and cleft lip. The cleft may extend completely through the hard and soft palates into the nasal area. Some infants have difficulty with nasal regurgitation and feeding. The cause of this condition is a failure in embryonic development. These birth defects are apparent during newborn examination. Parents may want an appointment to discuss the condition and treatment with the physician. Cleft abnormalities are pretty obvious during clinical inspection at birth. I mean, they're pretty noticeable. I think there's a picture in your book you can check out if you've never seen a child or a picture of a child with cleft lip or cleft palate. Treatment involves surgery to repair the cleft deformities. Extensive deformities require a second surgery to repair them. Special feeding devices may need to be used if the kids are having trouble with that whole nasal regurgitation business. Speech therapy is also needed. Prognosis is pretty good for this disorder with surgical repair. Also, lately advances in plastic surgery have made the repair look as natural as possible, and no prevention of this disorder is known. Cryptorchidism is a failure of the testicles to descend from the abdominal cavity into the scrotum, and it'll be detected at birth or shortly thereafter. So during infancy and early childhood, there are no symptoms, but this condition is palpable and observed during newborn exam. Diagnosis is by visual inspection and by palpation, starting above the inguinal ring and pushing downward on the inguinal canal toward the scrotum. Cause of failure of the testes to descend is not clearly understood, and treatment involves placing the undescended testes in the scrotum by either surgical manipulation, which is called an orchiopexy, that's the procedure, or hormonal drug therapy. So treatment is important because untreated cryptorchidism may lead to sterility in the adult male. There's an increased risk of testicular cancer in untreated cryptorchidism also. There is no accepted form of prevention, unfortunately. A Wilms tumor is also known as a nephroblastoma, and it's a highly malignant neoplasm of the kidney that affects children younger than 10 years. Nephroblastomas are the fourth most common childhood cancer, and about 20% of these cases of Wilms tumor are hereditary. However, there is no method to identify gene carriers. So we know that it's hereditary, but we're not sure how to identify where it's coming from in the genetic line. The most common presentation is a mass in the kidney region. The mass is going to be firm, non-tender, and usually confined to one side of the body. Some symptoms patients might experience as a result of the tumor are hematuria, so blood in the urine, pain in the abdomen or chest, hypertension, anemia, vomiting, intestinal obstruction, constipation, weight loss, and fever. A child experiencing any of those symptoms, especially hematuria, pain, and vomiting, and who has had a noticeable mass in the kidney region, needs prompt assessment. I mean, like, you need to get on that because these cancers grow very quickly. Adenosarcoma is arising from, an adenosarcoma arising from abnormal fetal kidney tissue left behind. So sometimes these cancers can arise from abnormal tissue that was left behind. So patient often undergoes a physical examination to palpate the kidney mass, to seek associated congenital anomalies, and to look for signs of malignancy. Surgical removal of the tumor and accessible metastatic sites is followed by chemotherapy with or without radiation therapy. So some notes here about Wilms tumors for you to know. Most children are treated based on research protocols at pediatric cancer centers. The specific treatment choice is guided by tumor stage and histology, so how advanced this tumor is and the histology of the tumor. Wilms tumor has been one of the has one of the highest survival rates of all childhood cancers. The prognosis is largely based on stage and tumor histology. Patients with a low stage and favorable tumor histology have a greater than 90% cure rate, so that's pretty fantastic news as far as childhood cancers go. The next condition is phimosis. And this first part kind of rhymes, so it makes me laugh every time I read it, but phimosis is stenosis, and stenosis is a narrowing of the opening of the foreskin in the male that leads to an inability to retract the foreskin. This can be problematic if acquired after the neonatal period, and that can be problematic for a number of reasons. First of all, what happens is, and I believe that there's a picture in your textbook, but the foreskin is up over the head of the penis, and so with phimosis, they can't pull it back down so that they can urinate and clean their area, all their business appropriately. So it makes it a little bit difficult and leads to lots of health problems for them in that area. So the child may have difficulty with urination, or the parents may have difficulty with cleaning the area under the prepuce of the glans penis, so underneath the head of the penis. These symptoms may develop later in uncircumcised males, even into adulthood. So sometimes males who have been uncircumcised grow and are, 40, 50 years old, who then have to undergo a circumcision because of this phimosis. So the diagnosis is made by visual examination and the inability to slide the prepuce back over the glans penis, so that they can't slide their foreskin back. The cause of phimosis is unknown. A definitive treatment is circumcision. Like I said, I mean, if a man has been left uncircumcised and has developed this condition at 30, 40, 50, 60 years old, then circumcision is going to be the go-to treatment for that. That's why it's problematic if it's acquired after the neonatal period, because most people prefer to have a circumcision done right after birth. So an alternative treatment when parents decide not to have the surgery performed on a male infant is for parents to gently wash the glans and the foreskin with soap and water and gently slide the prepuce back over the glans. So they have to wash it and try to slide it back over after it's been cleaned up. Okay, so congenital pyloric stenosis is a congenital disorder, as the name implies. It's a gastric obstruction associated with the narrowing of the pyloric sphincter, which is at the exit of the stomach. Symptoms include projectile vomiting, failure to gain weight. The infant will become dehydrated and experience electrolyte imbalances. The infant with sudden onset of projectile vomiting requires prompt assessment because pyloric stenosis could be the implicating factor there, or could be at the cause of their projectile vomiting. There's a slight hereditary tendency, but the exact cause for pyloric stenosis is unknown. The condition is diagnosed from the history and the patient's physical condition. Treatment is surgical intervention, and it consists of in which the constricted pylorus is incised, which is a pyloromyotomy, and sutured to relieve the obstruction. So basically, they go in and they will clip the constriction portion and then suture it up so that there's no longer an obstruction there. So the prognosis is pretty good for these kids as long as they have prompt surgical intervention. Hirschsprung disease is a congenital condition, and it's an impairment of intestinal motility that causes obstruction of the distal colon. Symptoms in newborns, they fail to pass meconium, which is that really thick, tarry first couple of stools that they have. They have failure to thrive, and then vomiting also. So when the condition worsens, the infant may become feverish as well and may have explosive and watery diarrhea. The signs and symptoms differ slightly depending on the age of the child experiencing an exacerbation of the condition. Infants or children with GI symptoms of bile-stained or fecal vomitus require prompt assessment, as do those children with obstinate constipation, especially when combined with vomiting and abdominal distension. The older child exhibits more chronic symptoms, so they have like more chronic diarrhea, more chronic vomiting. It's not so explosive or intense as it is when they're littler. Parasympathetic nerve ganglion cells are absent in a segment of the colon. So this deficiency of innervation results in a lack of peristalsis, or the movement of food, in the affected portion of the colon. Statistics will indicate that males are more likely than females to have a megacolon, or an enlarged big colon, and that the risk is increased in children with Down syndrome. It's believed that Hirschsprung is a familial congenital disease. Diagnosis is based on family history, the clinical picture, radiographic studies of the bowel, and finally, biopsy that confirms the absence of the ganglionic cells. Treatment includes having the affected portion of the bowel be excised or taken out, and then the normal colon is joined to the anus. Sometimes that's called anastomosis. A temporary colostomy will be performed as well. So some other metabolic disorders to talk about, we have cystic fibrosis, and this is a hereditary autosomal recessive trait that causes chronic dysfunction of the exocrine glands. Phenylketonuria, which is also known as PKU, is a hereditary autosomal recessive trait that causes ineffective protein metabolism due to enzyme deficiency. That's sometimes called an inborn error of metabolism. So a blood and urine test is given to the infant shortly after birth to test for phenylketonuria. If you're a mom, then you may remember, or even a dad, you may remember when your child was born, they came in and did a heel poke on the baby, and then sent tests off to the state. So that's what one of the things that they were testing for with those infant tests is PKU. So restricting phenylalanine from the newborn's diet will help prevent brain damage for a PKU baby. So let's talk a little bit more about cystic fibrosis. It's an autosomal recessive inherited disorder, and it's also a chronic dysfunction of a gene called the cystic fibrosis transmembrane conductance regulator, or CFTR, which is a lot easier to say. That affects multiple body systems. Basically, you have this thick, sticky mucus that accumulates and obstructs the glandular ducts. The clinical effects include a dry proximal cough, exercise intolerance, so they can't exercise very well without going into this dry cough, pneumonia, bulky diarrhea, vomiting, and bowel obstruction. Normal growth and ability to thrive are very reduced for these kids. Pancreatic changes replace normal tissue with fat and fiber. Also, sweat glands for CF patients increase their concentration of salt. A workup will be done on a CF patient to include a family history, pulmonary function test, any chest x-rays, and then stool studies. Genetic testing can be done prenatally if parents are known to be carriers of the genetic mutation for cystic fibrosis. Treatment includes supportive measures to help the child lead as normal of a life as possible. So supportive measures include the use of high-calorie, high-sodium chloride diets, chest physiotherapy, vitamin supplements with A, D, E, and K, increased fluid intake, and then pancreatic enzyme supplementation to aid in digestion. Also, broad-spectrum antibiotics are used aggressively to treat infections, and drugs are given to thin the mucus. The mucus in cystic fibrosis patients is very, very thick, and so that clogs their airway, making it difficult for them to breathe. So when they go into those dry coughing spells and they already can't breathe because they have blockages from this thick mucus, it becomes very problematic for them. Because cystic fibrosis is considered a fatal disease, the long-term prognosis is not favorable for these patients. So PKU is our next disorder to talk about, and phenylketonuria is an inborn error in the metabolism of amino acids that causes brain damage and mental retardation if it's not corrected. If it is corrected, then the problems aren't that bad, but if it's not corrected or if it's left undetected, then we could have big problems for baby. So an enzyme is needed to change the phenylalanine in the body into tyrosine is lacking. So this baby's body does not have the needed enzyme to convert this phenylalanine into the tyrosine, and that needs to happen. So the symptoms include a characteristic musty odor of the child's perspiration and urine, rashes, irritability, hyperactivity, and then also personality disorders. PKU is an inherited autosomal recessive trait, and the cause is defective enzymatic conversion and the protein metabolism. Screening of all newborns is mandatory in all states, and a positive screen indicates immediate dietary intervention. So fortunately, PKU errors can be fixed with dietary restrictions for the baby, and that can help the baby lead a fairly normal life. So PKU is detected by a mandatory screening of the newborn blood. Like I think I mentioned a couple of slides ago, if you are a parent and your child, you remember them doing the heel sticks on the babies in the hospital, this is one of the things that they're testing for, is PKU. A positive Guthrie test result will indicate the presence of phenylalanine in the blood. So treatment. We place the infant on phenylalanine-free diet that allows the infant to grow with normal brain development. Individuals with PKU must eat a diet very low in phenolane for the rest of their lives. So, I mean, this is a lifelong thing. But if the baby is raised to only eat food selections from this particular diet, then it won't be that big of a deal for them when they're older. The patient remains on a protein-restricted diet. And so a note here, restriction or elimination of the following foods is required for this PKU diet. There is no meat, chicken, fish, cheese, nuts, and no dairy products. Newborns cannot have breast milk, and starchy foods, any starchy foods, corn or rice, anything like that, those are going to be very closely monitored. The prognosis is actually excellent when the infant is placed on a phenolane-free diet soon after birth, and close follow-up with testing for phenylalanine levels in the blood may allow some modification of the difficult dietary restrictions. So if their levels aren't as critical as they could be, then they may loosen up a little bit of those dietary restrictions for that child. Okay, so moving on to endocrine syndromes. These syndromes result from non-disjunction or the failure of a chromosome pair to separate during gamete production. Sometimes extra chromosomes or the absence of chromosomes in the fertilized ovum cause congenital syndromes with a variety of physical and mental effects. So a couple of notes here for you. Each ovum normally contains a single X chromosome, and sperm cells may contain either an X or a Y chromosome. Okay, so if the baby is born with an X and another X chromosome, then she will be a girl. And if the baby is an XY chromosome, they're always going to get the X from the mom. And then if the dad gives the baby a Y chromosome, then he will be a boy baby. So some syndromes here regarding these X and Y syndromes. Klinefelter syndrome is also known as XXY condition. It's a male hypogonadism. It appears in males after puberty with at least 2 X chromosomes and 1 or more Y chromosomes. So most of the time with Klinefelters, they don't know that the baby has Klinefelters until that child reaches puberty. The presence of 2 X chromosomes in affected males causes abnormal development of the testes and then also reduced levels of testosterone. A person appears normal except for exceptionally long legs, above average height, and then reduced muscle development. So some notes I would like for you to know here. Puberty begins at the usual time and usually results in a normal-sized penis, but the testes are small and body hair is scant. So the kid, again, looks normal. This boy, a Klinefelter syndrome child would look normal and he would probably develop a normal sized penis, but his testicles will be smaller and he will have very little body hair. So he won't be a super hairy kid. Alternations in the affected female are a mild delay in language acquisition and increased risk of behavioral and learning disabilities. Some affected individuals have mild to more significant intellectual impairment. And then lastly here, the male infant appears normal at birth and symptoms are usually not noted until puberty. The condition may be discovered during a routine sports or pre-camp physical. So again, these kids look normal and it's not discovered until they begin to go through the puberty stage that, they've got some chromosomal abnormalities. Klinefelter is rarely seen in females. A little bit more on Klinefelter. It results from the presence of at least 2 X chromosomes. Typically, chromosome 47 will have an XXY pattern. The extra X chromosome may be of either maternal or paternal origin. The diagnostic workup includes a physical examination, serum and urine gonadotropin level determination, and then also a semen analysis. So at the time of normal puberty, long-term hormone replacement with testosterone by injections or transdermal patch is given. Testosterone is necessary for the maintenance of normal sexual function and normal muscle and bone mass. Many patients report an improvement in energy and emotional stability with hormone therapy. So basically, if this kid has Klinefelters, then he's probably, once he hits puberty, is going to go on testosterone injections, or they can do a patch, a medicated patch, and have him receive testosterone in that fashion. Unfortunately, fertility cannot be restored, so the possibility of fathering children is unlikely for Klinefelter's patients. And there is no prevention known for Klinefelters. Okay, Turner syndrome is the next syndrome, and it's a chromosomal disease that occurs in females with a single sex chromosome, and that's chromosome 45. It has an XO. At birth, the ovaries are immature or absent in these babies, and the female infant appears short with low-set ears, swollen hands and feet, and a webbing of the neck. They experience lack of sexual maturation along with amenorrhea, which means they don't have any periods, sterility, dwarfism, and cardiac and kidney defects. Cardiac defects, a little side note here, may include coarctation of the aorta in an infant and also adulthood aortic dissection due to cardiovascular disease. If the ovaries were present at birth, they slowly will begin to disappear and they will only end up leaving small amounts of ovarian tissue. Well, baby exams may reveal signs of the disorder, but they don't always catch it. And then lastly here, the baby is going to be referred for chromosome studies to confirm the diagnosis. So she'll be referred to a geneticist to confirm or deny the diagnosis for Turner syndrome. Turner syndrome results from the loss of the second X chromosome. A chromosomal smear study will show only one X chromosome instead of the normal 46 2X chromosomal pattern. Symptoms can be reduced by estrogen and growth hormone therapy. Surgical correction may be indicated for some of the anomalies associated with Turner syndrome. There is no cure for this disorder. However, the prognosis is good if the patient has no other complicating conditions, including cardiac or kidney disorders. Because Turner syndrome is a chromosomal disorder, there is unfortunately no prevention. It's very likely that emotional support will be needed for the patient. Okay, so I think that's it for part 3 of chapter 2, and I will talk to you soon in part 4.